Today we're going to talk about pediatric emergency ultrasound. The topics we're going to focus on today are the vomiting child, dealing mainly with pyloric stenosis and malrotation, abdominal pain, focusing on appendicitis and intussusception, and then pelvic pain, talking about ovarian pathology in girls and testicular pathology in boys. Like with any imaging, we want to identify pathology, arrive at the diagnosis efficiently, and minimize discomfort. And for pediatric patients, ultrasound is really the ideal modality of choice. When you have a vomiting infant, there are two main categories of disease. There are medical causes, predominantly GE reflux, gastroenteritis, or formula allergies. But we're going to talk about surgical causes primarily, particularly pyloric stenosis, which presents with non-bilious vomiting, and malrotation with or without midgut volvulus, which can present with bilious vomiting. Pyloric stenosis is very common. It is 4 times more common in boys. It's always said it's more common in the firstborn, realizing that there are more firstborns than anybody, so everything is more common in firstborns. It does run in families. Interestingly, though it's more common in boys, if your mother had it, you are more likely to have it as a child. Pyloric stenosis is hypertrophy of the muscular channel, and it really occurs between the ages of 0 and 3 months, most commonly around 6 to 8 weeks. These children present with non-bilious, projectile, forceful vomiting. If it's gone on for a while, they may be dehydrated, have weight loss, poor urine output. Sometimes on the stomach, and in a more advanced case, you can see hyperperistalsis, as in this child here. You can see waves of contraction across the abdomen, and occasionally you can actually feel the hypertrophied pyloric muscle, which is referred to as an olive. To do an ultrasound for pyloric stenosis, you want to use a high-frequency linear transducer as preferable, warm gel just for patient comfort and cooperation, and you're going to scan the right upper quadrant. And somewhere between the supine and a full right lateral decubitus position, you're going to be able to lay out the pyloric channel, whether it's normal or abnormal. You have to have fluid in the antrum, and I'll show you pictures of that because that helps to distinguish the antrum from the pyloric channel. Criteria are varied. These are the ones that I use. Unilateral muscle wall thickness of greater than 3 millimeters. Some people use 3.5, some people use 2.5. Those are the most reliable things, however, the unilateral muscle thickness. Pyloric channel elongation is less reliable. I use 16 millimeters. Other authorities have used other numbers. But again, it's really the unilateral muscle thickness is the most reliable finding. Now, when you have a normal pylorus, things are very easy. So in this particular case, we have fluid in the stomach. It is right here in the dark liquid, separating the walls of the antrum. This is the duodenal bulb, and the pyloric channel is very narrow. Okay, it's very short, it's not thick, and this is the muscle that we're looking at, this hypoechoic band. At real time, when you're watching, it's easy to see fluid move through the antrum, through this narrow pylorus, in this case shooting out into the duodenal bulb. The duodenum is not dilated. This is a normal examination, and you can see the normal relationship of the superior mesenteric artery right back here where the pointer is and the superior mesenteric vein. Okay, this is a normal relationship which we'll get into with malrotation. When you have pyloric stenosis, you can see on this child very clearly there is a marked thickening of the pyloric channel. It is elongated. The mucosa here is this echogenic material, tends to get a little bit thick. You may get some pushback of the mucosa into the antrum, the so-called teat sign. Here is another case, very thick muscle of the pyloric channel. This is the duodenal bulb, which is actually deformed by the hypertrophied muscle. This would be the sonographic equivalent of the upper GI mushroom cap sign. Here's again this little mucosa pooching back into the antrum of the stomach. And again, the transverse image shows marked muscle thickening. There are multiple channels through here. Again, hypertrophied mucosa getting compressed. This might be sort of the double track sign that you can read about with upper GI. Harris Cohen has written a lot about this particular sign. So what are some pitfalls in the examination? If there's no fluid in the antrum, it can be difficult to tell a collapsed antrum from an elongated pyloric channel. If you let the child have too much fluid in the stomach, it pushes the pylorus posteriorly and it can be difficult to evaluate. And when that happens, you can wait or you can try a prone scan, and I'll show you an example of that. And lastly, you can have pylorospasm, where the channel will be long, but it tends not to be as thick as in real pyloric stenosis. So in this child, we haven't rolled him up on his side. He's looking supine. We do have some fluid over here in the antrum, but you can see my sonographer here has measured an elongated channel, but it's not thick. And as we roll the child up and get that fluid to go into the antrum, you can see that eventually the whole pyloric channel opens up. This muscle thickness is only about 1.5 millimeters. Fluid and air is seen to pass through, and this child is completely normal. Now here's a child, if you get one who does have pyloric stenosis and they're very thirsty and you offer them a bottle, they may drink this down very quickly. And when that happens, you can see that the pyloric channel starts to turn. So instead of being oriented this direction, it's turned posteriorly, or in the case on the right, it's even pointing the other direction. Now certainly that doesn't look normal, but it's hard to get a nice picture to convince the surgeons that this child has pyloric stenosis. So again, you can wait or you can turn them over, and here we're scanning through the back. Here's tip of liver, here's kidney, and we're able to see the pylorus very nicely, see that the muscle thickness is well over 3 millimeters and the channel is well over 1.6 centimeters in length, and you've now made the diagnosis much more efficiently. In this child with vomiting, again, there's fluid in the antrum, but the pyloric channel is elongated. Okay? It's 1.3 centimeters, but the muscle's not thick. And we're not particularly suspicious, but still, you have to prove that this opens up and that fluid moves from the antrum into the pylorus. And this may take 10 or 15 minutes of waiting, but it's well worth it. You don't want to send the surgeons in on a normal case. And here things have opened up. Here's our normal pyloric channel. It is short, it is not thick, and here's fluid moving into the duodenal bulb in a normal examination. The surgery for a pyloric stenosis is a pyloromyotomy. It's a longitudinal splitting of the pyloric muscle. It doesn't fix the pyloric stenosis, but it relieves the obstruction by letting the lumen expand. This is the mucosa that will pop through, and this will eventually scar over and heal in just fine. So midgut malrotation is a little more serious condition. It's an anomaly of rotation of fixation during development, and you have an abnormal duodenal-jejunal junction. Instead of, in this child with upper GI, instead of the duodenal-jejunal junction being at the level of the duodenal bulb to the left of the spine, it's much too low. And the importance of this is that means you have a short mesentery. And if there's a short small bowel mesentery, that intestine is more prone to twist and to cause an obstruction, and ultimately even can cause intestinal ischemia. These children usually present in the first week of life, although they can present at any time. These kids are typically ill with bilious emesis. They have varying degrees of duodenal obstruction, and depending on the severity of the volvulus and how long it's gone on, varying degrees of intestinal ischemia. So while this is typically a diagnosis for upper GI and not ultrasound, there are things we can tell with ultrasound, and I think it's worth looking at in any child with vomiting. Normally, as we saw, the SMA and SMV are positioned such that the SMA is posterior and to the left of the superior mesenteric vein. When you have malrotation, these relationships change, and typically you'll have the SMA to the right of the SMV. Now, this is not universal, unfortunately. There are false positives and negatives. Other things we can look for are a fluid-filled proximal duodenum, indicating obstruction, or a mesenteric whirlpool sign, which shows the rotation of the vessels. So in this particular child who came to us with non-bilious vomiting, we had a normal pyloric stenosis study, but a part of our routine is to look at the position of the SMA and SMV. Now, you don't even have to bother Dopplering. The SMA always has this little echogenic collar of fat around it. No matter how skinny the child, okay, there's always this collar of fat. So this is the SMA and this is the SMV, and this is an abnormal relationship. The SMA ought to be over here, not over on the other side. And sure enough, when we take this child over to fluoroscopy, the duodenal C-loop, instead of coming up to this level, which would be normal rotation, it's much too low. You can even see there's a little bit of bowel dilatation in this child with malrotation and intermittent volvulus. This child also had volvulus. This was an earlier case where we weren't routinely checking the SMA and SMV, but you can see that the duodenal bulb is abnormally dilated. So again, while I may not know the cause, this child has a post-pyloric duodenal obstruction, and in an ill child with bilious vomiting, you have to assume that that's midgut volvulus until proven otherwise.